and I don't know what it's like in the UK, but I'll tell you in North America, I've seen a lot of it. Um,
Hmm.
it's just hard. There's just not enough time because you're so focused on requirements and surfaces and canals and amount of teeth you're taking out rather than going, okay, let's just take a step back and let's focus on comprehensive dentistry. And occasionally you'll get a part-time instructor that pulls you aside and teaches you all this stuff.
Hello, Protrusive. I'm Jazz Galati, and welcome to another episode of the Protrusive Dental Podcast Back to Basics series. Today, we're covering this mammoth topic of treatment planning, right? Where do you even begin with treatment planning? Well, you begin here because I'm going to break it down with Dr. Paresh Shah from Canada, all about the fundamentals of the kind of conversations you have with your patients. What is the sort of mindset that you have when you're treatment planning? What are the stages? How can you actually use your experience and use what the patient's goals are to help inform the best treatment plan possible for your patient? It's something that I used to really puzzle me when I was a newly qualified dentist. I'd see a plan that was more complicated than just single tooth dentistry, and it would be like, how do I apply what I've learned from dental school to this patient in front of me? So it's something that you sort of refine as you gain more experience. And I'm hoping that after this episode, it's going to just give you that little bit more of an edge to allow you to think more rationally about your treatment planning. So like I said, I hope you've been enjoying this Back to Basics series. It's been great fun to make it, and the guests have been absolutely brilliant during this month. Thanks so much for watching. Now, if you have any more recommendations for topics, I'm always happy to hear them. You can DM me on Insta, you can comment below, or you can email me, jazz@protrusive.co.uk. I would love to hear your suggestions, and I can get the right guests on as well as you want. So the protrusive dental pearl I have for this episode is very relevant to treatment planning, and it's this. If you have a patient and you're treatment planning them and it's a bigger, more complicated problem, and I'm thinking like not just that it's multiple teeth, but even something like missing teeth, like something that's so common, right? The biggest problem I used to have is like if someone has missing teeth, then sometimes what dentists are unfortunately trained to do and do is for every patient that has a missing tooth, they say to the patient, okay, there are 4 or 5 things you can do. You can do nothing and accept the gap. You can have a bridge. You can have a resin bond bridge, a conventional bridge, or you can have an implant, or we can do orthodontics or whatever, right? And you give the same bloody options all the time. This is really confusing to patients, okay? So if you're unsure which treatment plan to recommend, then that just means the following, that you haven't asked enough questions. So one way to help you to be able to give them the best plan for them, the best plan for your patient, is to ask more questions. How long do you expect this to last? Do you want something removable or something fixed, something glued in? Do you want to be able to choose steak on it, or is it merely just for looks? What's your budget? These are the kind of questions you should be asking to a patient to figure out exactly what treatment plan you should recommend. And then you can just let them know that, yeah, all these other things exist, but based on what you said, what you told me, this is the most appropriate treatment plan. And that is a much better way to go than to give everyone the same bloody 5 options the whole time. It's better just to give them a customized, tailored recommendation that's going to meet their goals. So remember, if you're not quite sure, you need to just step back and ask more questions so you can understand your patient better. So I hope you enjoyed the series. I'm going to hit the episode now with Dr. Paresh Shah. And for the next episode, we're going to go back to basics for occlusion. So I know it's September, which is going to be Splintember, but we're going to tie in with like a bridge episode, which is going to be back to basics for occlusion. So I'll catch you in that one. Hope you enjoy this main episode with Dr. Paresh Shah, and I'll catch you in the outro. Dr. Paresh Shah, welcome to the Protrusive Dental Podcast. It's great to have you on. Your work on social media that I've seen, we've never met in person, but virtually, you're such a just a kind person. Been very nice on social media to speak with you, or DMing, comments, that kind of stuff, and just inspirational to see the kind of work you do. And we started chatting and stuff, and we thought it'd be really great to hear from you to pass on, because August has been like a back to basics month for the podcast, and it's been to pass on knowledge to young dentists about treatment planning 101. And it'd be really great to chat with you today. But for those people who don't know where you are, who you are and what you do, just give us a minute or so on just about you as a dentist.
Thanks. First of all, Jazzy, it's been really nice to connect with you. I appreciate it very much, and your really nice sentiments about me. I appreciate that as well. I love what you're doing as well, because I like how you've kind of broken up themes and you're giving people either practical tips to implement right away or food for thought. And I know for me, that food for thought is a big thing. So I've been practicing 30 years, and it's interesting. You didn't know this, so I'm not trying to do anything weird, but I'm right in the middle of almost finishing a textbook, and that textbook is partly about my story, but also it's not about teaching treatment planning, because there are lots of different ways, as you know, and different mentors and different systems. But the book is geared towards people who are, whether they're early in their career, middle, or late in their career, to rethink how you're approaching a patient. And that's not always easy, because I think part of it has to come through taking courses with, like, really good courses, and we could go on for hours about that, and having great mentors and really good study clubs that actually um, collaborate well together. So, a quick thing with mine, I after about 8 years, I was just kind of doing drill and fill dentistry. It didn't really know anything different, and my circle of friends were similar. We just, hey, you did this filling, you did this crown. Oh, I ended up doing 6 crowns one day. It was kind of cool. And then all of a sudden I got introduced to a program and a couple of mentors of mine now that from the University of Minnesota. And I went down there and started taking some courses, and it was a post-grad aesthetic program, but it wasn't all about aesthetics. All of a sudden I'm getting introduced to occlusion and treatment planning and diagnostics, and, having to put up casts and photos on a screen in front of a bunch of strangers. And it was like, whoa, what is this? And all of a sudden it became a CSI type of thing, where all of a sudden you're looking at casts and you see something there that shows up on an x-ray, that shows up on a perio chart. And it's like, oh, ding, ding, ding. And so I started looking at things differently. And all of a sudden I'm coming back into my practice and I'm like, okay, that crooked area, like, I know what I can do for it. And it started evolving that way. And then I started looking at things differently when I was doing my exams, because now I wasn't looking to find always just a restorative solution, but I was seeing other possibilities. I was seeing implants, I was seeing oral surgery, I was seeing perio, I was seeing ortho. But other people had to open my eyes to that. And I think part of the challenge is when you get out of school, there's just not enough time to teach comprehensive dentistry. I feel, and I don't know what it's like in the UK, but I'll tell you, in North America, I've seen a lot of it. It's just hard. There's just not enough time, because you're so focused on requirements and surfaces and canals and amount of teeth you're taking out, rather than going, okay, let's just take a step back and let's focus on comprehensive dentistry. And occasionally you'll get a part-time instructor that pulls you aside and teaches you all this stuff, but you can't talk about it in school. And so anyway, I'm rambling, but that's how my practice has evolved. And then slowly as we went, I have a very close buddy of mine, Ken, and we kind of went on a CE journey, and we did COIS, and we've done MISH, and we've just come back, and because we're buddies, we can help each other to reinforce what we've learned and go, okay, well, let's slow down a little. Let's focus on learning the occlusion and implementing it in practice, and then going on. So now I'm at the stage where, I love what I do, and so much that after 30 years, I bought a building and built a new practice rather than retiring like some of my friends.
Amazing.
That's me.
Good for you. Yeah. Amazing. Well, is it lovely to hear your journey? I didn't know about the textbook. That is amazing. I mean, the amount of work and effort, I can only imagine how many, it's something you measure in years rather than how many months. I'm sure it's been a project that's spanning years, right?
Well, it came to fruition early in COVID, but it's been a lot of my journey. So what I'm trying to do is get people to just, retrospectively, I'm going back to cases that I did 10, 15, 20 years ago and go, okay, well, what could I have done differently? Like, it worked out, but what did I learn? What do we know now? Like, we've got CBCT, we've got so many different things that allow us to diagnose, at a higher level, and knowing that, hey, orthodontics plays a key role in getting teeth lined up better. So maybe we could do minimally invasive dentistry. And so just, when we're in our day-to-day routine, we see simple thing, lower anterior crowding. And, people will, but you got crooked teeth on the top, person's only focused on just fixing those teeth. But you and I know that after 10, 15, 20 years, those teeth will keep shifting. And there's a possibility that you'll get either mobility on those teeth, wear on those lower teeth, or mobility on the top teeth, or the veneers will chip. Like, our body compensates in some way. Ignoring it, we could get lucky, but there's also a possibility we don't. And then what happens? So why not just get that fixed and lined up in the right spot? And yeah, if a person wants to just shave them down, well, fine, but at least discuss the ramifications. But you see that if not every day, every week in practice. So why not at least approach it in a different manner than going, oh yeah, I can fix those 6 teeth or 8 teeth on the top. But why don't we put this fixed, like, let's look at this first, get everything stable, and then you may not even have to cut down these top teeth. Maybe we can do it with some bonding. As you call it in Europe, it's called edge bonding, right? In North America, they just call it bonding. But it's the same. Like, why not do that? And approaching it in different ways. You know, if the tissue heights are off, well, why not discuss it ahead of time? And maybe orthodontics or maybe crown lengthening might help, not just making one crown look really long and one short. It's just little things that sometimes we're not taught to look for, or we don't know how to address it or even talk to the patient about. And there's a lot of dentistry in the general practice. You know that. There's tons of dentistry, but it's just how we glean it and take it out and discuss it with the patients.
Well, those little light bulb moments, right? Our mind can only see what our brain knows, right? It's that kind of thing. So exactly like you said,
Right.
going back to full circle to what you said at the beginning, until you went on that residency program, you opened your eyes. So unless you've treated someone with the upper anteriors, using that same example that you gave of lower incisor crowding, unless you've treated someone on the upper incisor only and followed them up and seen a relative failure many years later and then thought, that's why this happened, then the way to fast track that is to learn about it either from a mentor or from a course. And it's about almost standing on the shoulder of giants and learning from others' mistakes. And you can then start implementing that. So sometimes it's seeing and then learning that, okay, this is a potential thing I need to have that conversation about. And it all goes back to that exam. I know this episode is Treatment Planning 101, very much designed for young dentists. And I'm keen as this episode progresses to really pick your brain here, which will be amazing. And it's such a vast topic. Like, we can go in any direction. But the first place I want to start with, if you don't mind, Paresh, is just to get some order and structure is the examination. Because I think your examination, the quality of your examination will dictate what kind of treatment plan you can present. So just talk us through step by step, even if it's like something that starts before the patient actually lands in the chair. Step by step, what is it that you're doing to the patient? What are you saying to them? And then how do you come up with your diagnoses?
Okay, that's great. So I feel the medical and dental history is key. I know it sounds so, like, medical history just sounds so moot, but the thing is, we know now compared to when I first got out of school that there are so many little clues that can lead towards just, at least making sure we're not ruling out any gastric issues, sleep issues, things like that. So, and certain medications in terms of bleeding and so forth. So it's nice to have that. But the dental history is key. I'm not a mentor at the Koi Center, but John's been it's one of the courses that I've done. So I actually use his dental history. And the reason I use it is because it's just broken up into subsets and I don't have to reinvent the wheel. That's essentially what it is. But as long as you have a good dental history that asks specific, not general questions that you can just find off the internet, like really specific questions about the 4 main categories that no matter where you go, I'm sure some of your mentors have talked, hey, you've got to look at biology, you look at the periodontal foundation. You've got to look at the structure of the teeth, like how heavily restored are the teeth. You've got to look at your TMJ and muscles. So ask a few questions about that, and asking a few questions about aesthetics, like what's important to the patient. Okay. So if we have questions like that, it allows me before they come in. And if you're an existing patient and I've been seeing a bunch of things and now you're finally saying to me, oh man, I wish I did this, or I wish I did that years ago. And you go, you know what? There's still time we can do a few things. Let's bring you back and we're going to take between an hour and a half and 2 hours and do a comprehensive oral exam. And this is the same thing we would tell a new patient, but I would tell you that as an existing patient. And because it's been a long
Hmm.
time, there's a lot of new procedures, technologies, materials that are available, and we might be able to address some of the concerns that you had. And some of it might be a little extensive, some of it might be simple, but let's reset.
Just wanted to highlight something for those listening, because I think there's a real gem in what you said there. Like in our busy practices, sometimes I've taken over a list whereby the same dentist was there for 34 years, and now I've just taken over his list, and his patients are all in the 60s and stuff, right? And now sometimes the needs or the wants of the patient deserves more than a 15-minute check. And it's having that courage to say to the patient, look, I've done my basic screening, okay, few issues to discuss, fine, we can do that. But based on what you said or based on what I found, you actually need a full, thorough assessment like you would have had, many years ago. And it's about having the courage and the conviction and the confidence to say that to a patient, to bring them back and then carry out that full examination to then come up with a better suggestion, better plan. So it's about remembering that just because you only have 15 minutes doesn't mean you have to cram everything in. You totally need to, as a young dentist, sometimes you feel shy or concerned or worried about inviting someone back.
Absolutely. And listen, if you're worried about, I don't like this phrase. I don't want to step on toes, because I think that's a pile of crap. I mean, at some point in time, you've got to be bold, but not reckless. You know what I mean? And the bottom line is, you have a dentist that you respected, or dentists that you respected whose practice you took over or you're working with, or that did the previous exam. For me, I just said, listen, when I took over my practice, it was really heavily restorative driven, because that was back, he graduated in the 60s and I took over in the 90s. Perio wasn't a big thing. So a lot of times he was just cleaning the floor 6 anteriors with a Cavitron, and that was it. And all of a sudden, I come out of dental school, perio was a foundation, and they're going like, "What are you doing? Why are you spending so much time cleaning teeth?" And I go, "Well, listen, back when John retired, when he came out of school, there were a lot of cavities. We have less cavities, so they weren't focusing on foundation. We're focusing on." So I wasn't throwing him under the bus. I was just reframing things. So it's the same thing. You go, listen, there are a lot of things that have changed right now. We have new materials. We have new composites. We have new ceramics. We have aligners, which we weren't using 20 years ago. So there are things that we might be able to do to help improve your smile in a conservative manner. But I need more time. And one of the things that's important, I don't think we take enough. I'm not saying all the time, but every few years, I think we need to, especially with people who have a lot of posterior restorative, taking full mouth series. We have to. We got to be able to diagnose everything. We got to diagnose the margins, caries, everything. Now I'm rambling. So what I will suggest is that having a good dental history that will have some questions that can potentially lead to they're more open-ended questions, because they can if they put a yes there, you can have a lot of other things you can ask. If they said, "Well, I have a fear of dentists," well, tell me about that. What happened? How? Or, "Hey, my bonding always chips." I had that this week. Someone came in for consult. Well, a person did bonding 8 months ago and it's all broken, but she has edge-to-edge occlusion and shear fractures. And she goes, "So I don't want bonding. I just want veneers." And I go, "Well, it's not about veneers. It's your bite's not in the right spot. It's not engineered properly. So I would rather you consider seeing my orthodontist, and then I'll do some bonding." "Well, but bonding doesn't work." And, "No, it's not the bonding." And so, but you can't do that in a 5-minute exam. So our new patient, we ask them to come in and have a comprehensive oral exam. And part of that involves a periodontal assessment.
I mean, so that's like doing pocket depth charts on every single tooth, right?
Exactly what we're doing with the periodontists that I choose to work with, which means not just pocketing, bleeding scores, clinical attachment loss, mobilities, recession, everything. That way, and how do you do that? Bring in a periodontist, bring in one of the periodontists that you work with and say, "Look, let's work with the hygienist. Here's what we need. Here's the why." When we finish, okay, so that's a perio, and I'll get back to that in a sec, but that's the perio assessment. Photographs, taking a full face photograph and a few digital SLR photographs, at least a smile, occlusal shots. How do we get the assistants trained? Well, now I had Sonny come in and do that. But before that, my orthodontist, hey, most orthodontists do fantastic photos, and my best friend's an orthodontist. So send the team to the orthodontist. They spend an hour and a half with our cameras and retractors. Done. Now they know how to take pictures. Okay. So they come in and they take the pictures. We'll take basic series of x-rays. And if there's a lot of restorative, then I'll say, we'll talk about it and go, you know what, we need a full mouth series. And then in terms of the aesthetics, what I'm getting the hygienic, now they're coming in, if it's a new patient exam, there's two ways to do it, but they're coming in right now in the hygiene appointment. And I know there's philosophically some dentists go, no, I got to see first, the other way. I feel if you can train your hygienist well enough to at least gather the information appropriately, they can get started on some things and do the fact finding. That's my feeling. Mm-hmm. And so they're coming in. So I have two entry points in the practice. One is straight with me, which would be about an hour, and one would be with hygiene. It would be closer to about an hour and 45 minutes. Okay.
Wow.
And so when they come in there, they'll gather the information, but the first thing I ask them to do is just to sit down, and because the same way as I would, and go through the dental medical history, sit eye level with one another and just go over the questions and not get hung up on, I got to get the bib on and I got to start cleaning teeth. No, this is about connecting, getting to know the patient's why, their fears, what their expectations are, and build a relationship in that first little bit. And I tell the hygienist, if you don't pick up a scaler that first appointment, that's okay. Because if that person needs the time to talk, gather information, because it's a complicated case, it's okay.
It's good as a hygienist to hear that from your boss, right? So you don't have the pressure. You can just do be as thorough and as complete as you want to be.
Right, and it's important for the patient to understand that. That's why sometimes, a lot of times, they'll start in the hygiene, because if it's a simple condition, they can get some of the active therapy started or even done, and the patient's happy. But if they don't, as long as you have good verbal skills and you feel confident enough, you can communicate that, listen, Jazz, you've got a complicated case. Your teeth are not straight. You've got a lot of inflammation. We need to spend a little more time trying to figure out how to get you healthier. And so I don't think we're going to be able to get started today. I need these measurements so when Dr. Shah comes in, we can have a really good conversation about how we can get started with you. And if you build that value, it does work. I've seen it. It does work.
And the other thing that might do, Dr. Shah, is if you have that patient who's just not playing ball with that, then that's probably not the patient that you want in the practice anyway, right? So it gets rid of the weeds.
Right. So I'm glad you said that, because when I built the new practice, I really defined core values as strategic anchors. And one of the strategic anchors is we want our patients to partner in their care. And so the entire team, including the admin, they know that. So I sometimes when they newly started with me, they go, this person doesn't want x-rays. I go, well, how does that fit with our strategic anchors? Well, it doesn't. They go, okay, so you know the answer, right? So explain the value of it and just say, listen, in our practice, our patients are used to having that and partnering in their care. Here's what we do. And they have to sign off a form that they don't want it. But if they're refusing everything, then we just say, look, this probably isn't the practice for you. Yeah. And it's hard when you're a young dentist and during COVID and it hasn't been busy. Yeah. But that's what we're doing. That's what we've been doing. But I've got those are the records that I'm trying to gather in a comprehensive exam I'll, if they come to see me first, I will gather those records. I don't usually do the periodontal measurement. My hygienists are better at it. And I will tell them, I'll get a rough idea of what it looks like. And I'll say, Jazz, I'm going to schedule you with Aaron or Shane or Liz, and I'm going to be there that day. And they're going to take over the second part of it. And I just need a diagnosis, because one of the things that I want to do is I want to give every adult patient, a periodontal diagnosis, AAP classification. The reason I want them to own their condition, I don't want to own it. I don't want to own it. I want them to own it. And the bleeding score for the last 8 or 9 years since we've been doing this is so powerful, because my hygienists go, look, your bleeding score is like 13%. I want it at 5. Like, you got inflammation.
Mm-hmm.
And maybe you're not going to get bone loss from it, but you're going to objective measurements. And they see that chart and they see the red spots. I'll tell you, most of the patients own it, and they're like, oh, and so what do we do then? When the inflammation's high, what did you learn in school? A reeval. You come in at 6 weeks, just like at the perio, and you do a reevaluation. And Jazz, you got to do your homework during those 6 weeks, because we're going to take the measurement again. And if not, you're going to see our periodontist. And we do that. It takes extra time, but you know what? Our handoff also to our specialists for our periodontist is smoother, because they know what we do, and they don't sit and go through 8 months of treatment again. They just go, okay, we know what's happening here. Let's just get started with our surgical intervention or whatever we need to do. But the perio is a huge part of our practice, and that bleeding score and clinical attachment loss, it's powerful.
Absolutely, and you just reminded me of a couple of things as some of the themes we're hitting there. And one thing that, the importance of asking the right questions, as you do, as part of the set list you have. And one thing that I was always taught by a mentor was, if you're not quite sure what the treatment plan should be for your patient, you haven't asked enough questions. So that's one thing that I always keep in mind. That means, okay, I need to ask more questions, and then I will feel more certain myself what to recommend. It's a sign that I haven't obtained enough information. And the second thing is that you said about these set questions, and the importance of having a checklist of some sorts. And it reminds me of a dentist who came to shadow me one day, and she saw me do 2 new patient examinations. And then at the end of the examinations, he said, Jazz, I noticed that you did the exact same thing for those 2 patients. Yes, they were individual. I treated them individually, and I came up with a different diagnosis and a plan. But the way I did things was exactly the same. And then she said, I never thought. I always just go with the flow with the patient. You seem to have a more structured way of doing it. So just tell us about the importance of having a structure. Are you a checklist kind of guy?
So in my lecture, even if it's a clinical lecture, I throw in the checklist manifesto made a huge impact on me years and years ago. And so I've read the book. Checklists are part of the fabric of the practice. And what we do is we create a checklist. In fact, my assistants, I've noticed in the last few weeks, I had a quick sidebar, had a conversation with the team. I was noticing that the communication wasn't great with the assistants, hygienists, and admin. And I said, listen, no one's using the checklist regularly. We need to get back to it. There's just too much information during the workflow to worry about stocking toilet paper and stuff. I mean, that's a checklist thing. Don't clutter your mind. Like, we got to focus on patient care and our team, and not go, oh my God, I'm worrying about putting paper towels back. Are you kidding me? So get back to the checklist. And the assistant said to me, you know what? You're starting to do things different with some of your restorative procedures. And I go, so what do we need to do? She goes, I need to update the checklist. I go, well, let's do it. I'll sit with you. So what we do is we laminate the checklist, and we have a dry erase pen. And so, yeah, there is a comprehensive exam. There is one for, veneer cement bonding. There is one for an annual periodontal maintenance. There's one for a comprehensive oral exam in the hygiene room.
It's clinical protocols, isn't it? It's clinical protocols as part of success.
Right. And I want them to check it off. And the reason I want to, even if it's something that they don't feel they need to do, I want them to physically check it off. I know it sounds mundane, but it's the same thing. I said this yesterday. I said, team, here's the thing. Picture yourself on the operating room table, because that happened to me last year, and I had my knee replacement, and everyone in the operating room introduced themselves to me and said what their role was. And there was someone in there with a checklist. I said, do you want that when you're in the operating room, or when you're going on a plane? Do you want the pilot to glance over the list, or do you want them to actually go, no, I did look and see that switch is there? That's all I have to say. I don't have to say anything else. And all I'm saying is it only takes you a second to check it that, hey, okay, I didn't need x-rays today, but yeah, I considered it. Boom. And so, yeah, the consistency, as you said, is important. And so that's what I do as well. And so we have a checklist in there and we'll go, okay, are we doing this? Are we doing that? Yeah, we grab it. And so sometimes your assistant, let's say you're doing the exam, they can actually get started before you come in, because maybe you're finishing an exam, they've taken the patient in, and they go, look, I know Paresh is going to want an intraoral scan, so let me just start it. I'll just take it. So when Paresh comes in, it's like, oh, you're taking the scan. Okay, I'll be back in a minute. Hi, Jazz. Nice to meet you. I'll be back in 2 minutes. And we're going. One of the other records we take is an intraoral scan. So in our comprehensive exam, every patient gets an intraoral scan. So we don't pull out the alginate and everything. And the hygienists do it if it's in the hygiene room. The assistants do it if it's in our room. And it honestly only takes them about 5 to 7 minutes. That's it. My assistants are faster. It takes 2 or 3 minutes, but I'm slower. It takes me more like 5 minutes. And but they do it. And the fear for them when I initially introduce is, oh, what are you going to do with it? I go, listen, it's strictly diagnostics. We want to print a model if I want to send an STL file to one of the specialists, but I'm not making crowns on it. Don't worry. And so that's part of the process that we do as well. So we're gathering periodontal charting, photographs. I also ask them to do all of the hard tissue charting on the chart as well, existing restorations and everything. So it does take time, but that allows me, if it's more complicated, I can sit now with the patient, introduce myself, talk about a few things and say, listen, I think do you realize now that your condition's a lot more complicated. You've got a couple of areas of decay here. Your tooth is drifting over here. An implant might help, but I'm going to need a cone beam, like a CT scan. So let's gather this. I'll bring you back and we can have a nice conversation over an hour rather than 5 minutes.
I mean, let's talk about that. So let's talk about the situation whereby you've gathered all the information, the patient's wants and desires, and now you've also found out the patient's needs. You've got the perio stuff, your ortho classification, you've got your imaging that you want. Do you always invite them back for a second visit to explain their findings? Do you do that virtually? Do you do it in person? Do you sometimes not need to do it if it's quite a straightforward maintenance case? Just give us a flavor to the young dentists about that.
Okay, so if it's a straightforward maintenance case, then I typically would just bring them in, start the next, book them in for their next restorative appointment. And if there are a few things that, how you're phasing treatment, and phase one, you want to treat caries and stabilize the perio. So, during that one, but there may be elective treatment that in terms of crowns and maybe a bridge or an implant or things like that, or ortho. So I will say, look, and here's our first phase. Let's get you scheduled, because the decay on a couple of these teeth are pretty bad, and I want to get that started right away and maybe minimize the risk of a root canal. So let's get you in there. And if I know there's other treatment that is elective but necessary, I will schedule extra time at the end of one of those appointments to go over it. If it's strictly elective, I'll say, look, let's get through, and it's just me. Let's get through all of the initial cavities, and then I'm going to bring you back and we're going to discuss elective treatment. And I'm going to give you, because I know at that time it's going to be things that I feel they can benefit from, but it might involve implants, it might involve ortho, and I don't want to do it in 5 minutes. I want to spend time showing them with their intraoral scan and their x-rays and everything. Look, why should you maybe consider uprighting these teeth?
But that's all at the end of phase one, isn't it? That's all at the end of disease management, right? You're having that chat again, which makes so much sense.
Right. Now, having said that, if their focus has been, hey, my aesthetics, and I got to get the smile, no, I'm going to bring them back. Yes, we can schedule their restorative appointment, but I'm going to show them a smile design. I'm going to do a mock-up on them. I'm going to do all of that, and I'm going to schedule a separate appointment. So when it comes to mock-ups and smile design, I'm going through a digital smile design process with my lab, or sometimes I'm doing it myself, and I'm designing the smile on ExoCAD. And then I'm printing a model, creating a mock-up. And if I don't have time, I get my lab to do that and send me the model and a stent. And then I'll do a putty matrix in the mouth, and I'll I'll go through that whole digital smile design process.
Do you bill for that? Just because different doctors do it differently. So some will do it as a motivational thing to just cement the idea that, hey, this is a good idea, and some doctors are afraid to charge because they want the patient to see the mock-up, right? Whereas others no, I don't want any tire kickers. I want to be able to bill for it to see if they're committed to that. So where do you lie on that?
I'm going through this process again after this many years. My team's like, you got to bill for it, and I'm like, maybe not. And so it's kind of a mixture. So part of it, if it's a simple smile design that I'm comfortable doing quickly myself on my own software, which I have ExoCAD, so I can use it. It doesn't take me long. So if I can do it in 10 to 15 minutes and then send the model to our printer and print it out the next day and so forth, I'm not charging. But if I get involved with the lab's charging a fee for that, and I'll tell the patient, look, there's going to be a lab fee for it, and I'll just charge them the lab fee, which is a couple $100. And so it's kind of a mixture, and I'm trying to get through that part right now. And I don't think there's a right or wrong answer, but it's a fair question to ask. So I'm still wishy-washy on it. I'm doing a little bit of both.
No, it was just good to know how different doctors do it. So your way is valid as well, and that's great. Now, once you have, like you said, all these different bits of information together, the funny thing is, Dr. Shah, and you'll appreciate this, is you and how you treat and plan now, and that same person who would have walked into you 15 years ago, they would get different treatment plans. And dare I even say it, even last week, morning, afternoon, slightly different treatment plans. It's just human nature. We know this, right? So how you treat and plan, how you diagnose, it's variable on time, experience, your mentorship that you have available to you. So I used to get very worked up about it. Like there's like so many different ways to treat this one individual. And newly qualified, I was like, should we go down this route? Should we go down that route? And then sometimes what young dentists end up doing is that we end up confusing the patient. We say, well, you could have this or you could have this. And then here's the pros and cons and here's the pros and cons. How do you, come up with a plan that you think is the best for the patient? How do you convey that to the patient? And then how do you also then, part of it, in the UK certainly, one of the sort of things that our regulator wants us to do is we have to offer alternatives and also the risk of no treatment. So you have to go through a lot of things. But how do you do it in a way that doesn't confuse the patient?
Oh, you know what? That's a great question, because, sometimes I've found myself in the past giving so much information that the patient goes through what we call analysis paralysis. And they're like, oh man, so much information. I just don't even want to talk about it. And then they just don't do anything. So I think number one, like Simon Sinek says, is finding out their why. Like, what is really, really the most important to them? And then from there, taking the information. Like I find for us, there was an interdisciplinary meeting that my two orthodontist buddies and my restorative buddy we went to, that was headed by Vince Kokich when he was alive years ago. It was about 20 years ago. And there were teams of oral surgery, perio, restorative, and up on stage, an ortho up on stage just showing a case. And there was a restorative doc that said something. She goes, you know what? We tend to look at things through restorative eyes, and the specialists look at things through specialty eyes. And what we're trying to do as a group is look through interdisciplinary eyes. We're trying to look at things a little different. And I think as restorative docs, our lowest common denominator is just, hey, I can do restorative. And so what I try and do is I'll try and decipher, and it's a little more complicated, I understand this, but I'll try and decipher I'll put together the problem list of the key things that are important to you. I'll add the things that I note. Okay, sidebar. There was a Jeff Morley and a Jimmy Eubank that have been teaching restorative and smile design like even 20 years ago, and I was taking a lot of their courses. And one of the things they taught me was to look at each of the records separately. So you take your x-rays and you just quickly analyze all of them, jot a few notes, put it away, pull up the clinical photos, jot a few notes, put it away, take the casts out, jot a few notes, pull the perio chart out, jot a few notes. And they say when you do that, all of a sudden you'll start seeing, hey, you've got a wear facet on a tooth. You look at the perio chart and there's a pocket or mobility, and then you look at the X-ray, and there's a widened PDL. I mean, I'm making it simple. It's all tied in. So I try and look at that quickly, jot a few notes, come up with the list, and then I'll say to you, okay, here are the things that you want to address. Now I can do this restoratively by doing this, this, this. Okay. However, if I do it restoratively, can you see this picture? Can you see this tooth? I'm going to have to be pretty aggressive with my treatment on these to correct what you want to have corrected. Because maybe it's a tooth that tipped, and let's just keep it simple. We've got drifting here. Someone wants an implant or a bridge, and I've got to really aggressively treat all of these teeth. Oh, well, what's the risk of that? Well, might need a root canal on these teeth. Well, I don't want root canals. Okay, but that's one. Well, what's another way? Well, if you would consider seeing my orthodontist or whatever, we could tip them up. Oh, but I don't have braces. I go, okay, well, I get it, but are you willing to accept cutting those teeth down? If you are, that's fine. And is there another risk? Yeah, I can cut these teeth down, but it's tipped so much that when I finish putting this crown, there's going to be a gap over here. You will get food in there. Mm-hmm. And it may not be important to you now, but 20 years from now, you're a little bit older, you're my age, and all of a sudden now you're getting all your food there. And I mean, I don't know about you, but I love eating food. I don't like picking it out of it. But this is a possibility. And so I start bringing it that way. And when you say risks and complications, I want them to understand it in practical terms, in relatable terms of what it's going to be. You know, they're not going to care about periodontal disease. They're going to care about, I'm getting all my lunch stuck in that area. And when I'm sitting with my friends at the dinner table, I don't want to be running to the washroom to clean it out. So give them something like that. So I try and break it up that way and give them a why as to what we can do. And now all of a sudden, it slowly opens up the conversation to other disciplines. Same thing with gummy smile or uneven gingival heights, and they've got a gummy smile. Is it important to you? So I just did this with a patient yesterday. And I asked her, she came in, so nice young girl. She's in her late 20s, beautiful smile, but they're just a little bit crooked, and the gingival heights aren't great, and her lip dynamics are a little high. So I mentioned, I said, look, there's several different ways that we can do this, but we got to figure out why you have a gummy smile. Is it skeletally, your jaw, the way it grew? Is it how much the teeth have erupted or not erupted even with the gum eruption? Or is it your lip is moving more than it should be?
Hypermobile.
And how important is it? And so, because that involves possibly orthognathic surgery, surgical crown lengthening, Botox, any of those. We know that, right? So all these other disciplines, because I can just throw veneers on there, but if she's going to be unhappy with her smile, I'm dead in the water. She's not going to be happy with them after. So what do? I did a mock-up. I just took some composite, I dried off her lips, I put some composite over the gum tissue of one tooth that was shorter. I lengthened two other teeth. I now opened up the conversation to three other disciplines. And you know what? She says, this is exactly what I want. I don't want to do anything else. Are you happy with the level and the way the reveal of the gum? Yeah, I'm happy. Perfect. Let's do some bonding. We'll trim this tissue. I'll sound the bone. That was it. But I brought up in relatable ways. I hope I'm not confusing everything. It's just something that they can relate to tangibly.
Exactly, and you showed her a visual aid to help come up with which would then inform the best of the many ways to treat her, because all those ways could have had a role, but in terms of what would get her happy and what doesn't involve perhaps orthodontic surgery, if that wouldn't be relevant or the correct sort of treatment for that individual. So that's very relevant.
Right, and so part of the whole thing is I've got my list, I've got my problem list, I've got the why, and now
I mean, that's brilliant, by the way. The problem, I just want to, just before you I just want to highlight, I forgot to highlight, the problem list is crucial. Something that I was taught when I'm doing the orthodontics, and orthodontists are really good at creating problem lists, but sometimes you forget that we can do it in all disciplines. And I like that how when you were saying the problem list before, you are relating it to in patient terms. So it's something that I feel as though it's a problem list that you feed back to the patient. So this is what I've understood. These are the problems, and these are the solutions to your problems. And I feel as though that's the very basis of the treatment planning.
It is, and I think I tend to, as I'm doing that, start first with restorative solutions, because that's what they can relate to. They're coming to get a filling, they're coming to get a crown, they're coming to get a veneer, but the risks of some of that can be mitigated possibly by crown lengthening, periodontal intervention, ortho intervention. So it allows me to then go, okay, well, if you don't want to cut this down, then I think you should at least have a consultation with my orthodontist, or you should at least have a conversation with my periodontist or my oral surgeon. And it opens up the interdisciplinary conversation rather than me just going in there, well, you need to see ortho, you need to see perio, you need to see this. And they're like, whoa, wait a minute, I didn't want that. I'm trying to relate it and let them make some of those choices. Go, well, I really don't want to cut these teeth down. Okay, that's fine. Mm-hmm. But if we can put them in the right spot, well, how long would it take? Well, you know what? Some of it is just unraveling some of the teeth. I use simple terms like they're all, they're all closed. Let's just unravel them a little bit. Now I don't have to touch them because they're beautiful teeth. We do some whitening, put the teeth in the right spot, and we'll fix these 3 chips on the bottom that wore down. Is that going to be expensive? And I go, well, you're going to spend the money on the orthodontics, but now you don't have to spell them on the teeth. And maybe 20 years from now, you're going to have, if something breaks, you're going to have the money and you're going to have the teeth to be able to keep them. So it's always taking it back to mitigating risk and allowing them to relate to, like, make the decision on, do they want to preserve tooth structure or not?
Well, you mentioned fees there and money, which is so important because, again, and it's something that a lot of dentists are guilty of. As a young dentist, in a few years out of dental school, the worst thing you could do is trying to diagnose someone's wallet, right? Trying to say, okay, well, I think this patient can afford this. To let me scale down my treatment plan to make it fit this imaginary budget that you come up with, which was totally the wrong way to do it. But equally, there are patients who just can't afford certain levels of care. So how do you present a treatment plan, and then also trying to make sure to try and do it in a way that the patient can it's within the patient's budget? Any tips on that as my final question?
Yes, I use the phrase "ortho is my best friend," and even though I don't do a lot, maybe like 5%, it's ortho. If you can put the teeth and the system, and now I'm using the word system not for patient, but I can say it with system, like the engineering of your bite is not ideal. It's wonky. Okay. It's just no different than when you've got shifting of piles under your house and the house is settling and you're wondering what the heck is going on, or the car is imbalanced. And very relatable terms. Like, do you want me to rebuild the house on those wonky piles, or would you rather let's take the piles out, get it nice and level? So your system isn't ideal. If we can put the system in the right spot, and yes, you're going to have to spend some money doing orthodontics. I can do single tooth dentistry for the rest of your life. If the teeth are all lined up properly and you can only afford 1 crown or 1 filling a year, fine, I'll do that. If you can afford 3 of them, I'll do 3 of them. But if they're crooked and everything and the bite's not good, I'm going to put it in a failing system. It's going to still, you risk wearing them down the road or chipping or breaking them. Go through orthodontics, line them up, keep your aligners. Some dentists will go, well, but then, I missed out on this. You know what? You're still going to make the money. You've got a healthy you've got a periodontal patient that's compliant. They come in regularly. So you don't make the $10,000 in one night. You make $15,000 over 5 years. It's an annuity. Like, you're still making it financially, but now you've got predictable work.
We need to hear that. That's very good.
Right. And so,
and now you have the satisfaction of knowing that you've done the best for the patient.
Right. And so if they choose not the ortho, then how do you do that? You transition them with transitional bonding, whether it's direct or whether it's with milled PMMA or something like that. You can do that. But when you do it that way, they are committing to some sort of treatment on some of the teeth, because you might be reshaping them. While with the ortho, you can just kind of stick them there. So you can still give them both options to stage treatment. And then they're going to have to deal with the maintenance of chipping some of the fillings or transitional bonding. And so you just say, listen, if they do chip or break, here's the fee for fixing it, but at least I can transition you over 4 or 5 years. If you can only afford a few $1,000s a year, your insurance maybe covers $1,000, and you say that you can probably put in a couple of thousand, but you got a $10,000 treatment, I'll get you there in 3 years. But the first year we're going to do is stabilize your decay, and we're going to just get your bite stable. And it's going to be one of two ways: orthodontics or transitional bonding.
Well, the main thing there, I think, to take away is that the foundations, the disease management is there, and that's part of the thing that you can't really compromise on. So you present that, and then what you also pretty much said there was that you haven't given them a plan and you try and diagnose their wallet or anything. You're giving them the ideal solution, and you're giving them the why related to them as why that is ideal. But you just might know that okay, instead of doing it all now, you're spreading it over time so they still get the best care. And I think that's the best way to summarize that.
Yeah, no, absolutely. And that's what I feel. So, I mean, I'm sure you have cases right now where it's taking 3-4 years because they're going through a lot of work. And sometimes you forget about it and go, damn, I'm not doing it. And then all of a sudden it's like, oh, they just finished orthopedic surgery, or they just finished this, and let's start going. And it's kind of fun because it's almost like, oh, I forgot about you. It's great. And but the thing is, it does. I don't know. I just find it more rewarding, and I'm sure you do too at your stage now. Mm-hmm. About that, I do feel it can be a little scary and daunting for a young clinician to look at all of this and go, oh my God, that's so much. But it really isn't, because if you really think about it, most dental schools, you went through and had to do at least 1 or 2 comprehensive care cases, I would assume, where you had a series of clinicians that you worked with. And that was probably the most intimidating, because there was one doctor that you knew was going to tear you apart with questions and literature. Mm-hmm. But you did it. And it's a matter of just, okay, going back to that foundation and just almost doing an overkill of what you feel might be an overkill of your exam, because that's what you really want to do. So just do that. Like, go back to that fundamental. And the other thing that I would say is find a mentor, find an experienced mentor that will walk you through gathering the information, showing you, if you're doing analog, why it's important to mount the cast rather than just holding it in your hand, and how to interpret this stuff. But actually sitting and listening, like you said, that young dentist, she watched you do exams, and watch and observe, because a big part of it is interpersonal communication when you have that information, and presenting it and communicating so that it makes sense and it's not jumbled up and it is relatable takes time. It's you can't be technical with the patient.
Amazing. Paresh, that's been really good. I mean, it's a big topic to cover, treatment planning, but I feel like the themes that we've got into is going to be quite helpful for young dentists as part of the Back to Basics series. Please, you must let me know when your textbook is out. I'd love to share it with the Protrusive. And again, if you're not already following Paresh on Instagram, please do check it out. His sensational work, a lot of amazing aesthetic work, veneers, ortho-restorative, complex plans. Sometimes these, just by seeing the work that's possible, inspires you. As a young dentist, sometimes you look ahead and you think, how am I going to complete that? But just by hearing Paresh's story today and seeing his development, and he did course and he did that residency, it's not something that happened like an overnight success. It's something that took time for you to build into. So as inspiration, I would encourage you to look at those cases.
Thank you so much, Jazz. I really enjoyed the conversation. And like you said, it's a very complex topic, and I hope it wasn't overly confusing or daunting, but if hopefully just took a few, some of the audience took a few pearls out of there.
it's those pearls that, the way we communicate to patients, or the way you present certain things, it's all about the conversations that we have on a day-to-day basis. And I thought this episode was full of those kind of conversations and the importance of a checklist, a lot of very foundational things which we don't talk about enough, I think. So again, thank you so much, and I hope you have an awesome weekend in Winnipeg, Canada, where you're based.
All right, thanks very much. I hope you have a great weekend as well.
Well, there we have it. Thanks so much for listening or watching all the way to the end. If you're listening on your podcast player, please do hit that subscribe button so you don't miss a single episode. If you're watching on YouTube or on Dental Tubules, hit that subscribe button. I'd really appreciate it as well. And I'll catch you in the next episode of the series.